My seventh lesson is that new challenges need new ways of thinking and behaving. And here are some data from our centre in Bangladesh, and it shows these are causes of death within MATLAB, which, as perhaps lots of you know, is a rural community in the south of Bangladesh that has been monitored. Everybody there has been monitored for some 50, 60 years. It's one of the oldest sites in the world where people have been looking very carefully at all the causes of death and the number of births, etc. And these data run from 1974 to 2006. And the blue there at the bottom is deaths from communicable disease. And you can see that they've come down from a peak of around 50% down now to perhaps less than 10%. And then the red is the non-communicable disease, the chronic disease, and you can see how there's really been a very dramatic growth between, say, 1987 and 2006. So in just 20 years, we've seen that in this rural community in Bangladesh, which is a poor community, this huge increase in non-communicable disease. And I don't think that the world has quite woken up to that yet, although these kind of data are borne out in many other kinds of studies. And here's some data from the US that is making the point that people with multiple chronic conditions account for almost all of the Medicare spend. So in fact, people with 5 or more chronic conditions are accounting for 2/3 of the Medicare spend. I mean, this and what's happening in Medicare will be happening in the rest of the healthcare system. I'm sure the data from here in Britain, if we had them in this form, would be very similar. So increasingly, clinical healthcare is about dealing with people with multiple chronic conditions, not single conditions, often elderly, often towards the end of their life. And I would argue that often what those people need is not a cardiologist or a gastroenterologist or a pulmonologist. They need somebody who thinks about all of the things that matter to them. And often it isn't their diseases, it's their social circumstances. And I wrote a piece recently arguing that perhaps in Britain we need to shift resources from the NHS to social care. I think, again, the world has not quite woken up to this. I don't know that medical schools have woken up to this. They sort of go on with the classic medical model of diagnose, treat and hopefully cure. Well, there's not a lot of curing going on anymore. This is the reality of healthcare, and it has profound implications. Here's a graph again from the US showing that as people develop more and more chronic conditions, their chances of having an unnecessary admission to hospital increase really exponentially. And certainly here in Britain, we know that probably about 40% of the people who are in hospital today in Britain, it's not the best place for them to be. They don't need to be there for the kind of care that's offered in the hospital. They're there because there aren't other places for them to go, and sadly we know that hospitals are dangerous places to be unless you have to be there. Well, they're dangerous even if you have to be there, but if you don't really need to be there and you've got the danger without the benefit, that's not good for anybody, plus it's generating lots of costs. So we need to begin to think in different ways. And this is a slide I took from Derek Yak, who's worked at WHO for years, and he contrasts, what do we need in order to respond to acute childhood infections and maternal deaths, the things that are in the Millennium Development Goals and where most emphasis is these days. And he contrasts that with what do we need to counter chronic, lifelong, infectious and non-infectious diseases. And of course, what we call these diseases, whether we call it chronic disease or non-communicable or diseases of civilization, we have lots and lots of arguments about that, and we never really quite resolve it. And I think we just have to define what we're talking about each time. So I tend to stick to chronic disease. So on the whole, you can potentially counter childhood infections with comparatively simple technologies, with vaccines, with malaria nets, etc. Whereas on the whole, something much more complex, reorienting the way people live, the circumstances in which they live to counter chronic disease. You can have rapid impact with acute childhood infections and maternal deaths. On the whole, the impact we're going to have with chronic disease, I mean, we're not going to be able to reverse that upward trend that we see in low and middle income countries rapidly. It's going to take quite some time. When it comes to childhood infections and maternal deaths, then a lot of the emphasis will be on health services. They're the people that can make the difference. But when it comes to chronic disease, the main levers are outside of health service control, doing something about smoking, making it easier for people to eat healthier diets, creating an environment in which it's easier for people to exercise. These are not things that can be done by the health services alone. And so what it means in terms of universities and physicians' organisations is that it can't just be the health campus and the health department. It needs to be the whole university. And here's a table that I took from a report in Scotland done by David Kerr, Professor of Oncology in Oxford, about how does the Scottish healthcare system need to change in order to adapt to the fact that increasingly it's dealing with people with chronic long-term conditions. And there at the top, you know, the current system is geared to people with acute conditions. It needs to change to working with people with long-term conditions. It needs to move from being hospital-centred to being embedded in communities. Easy to write on a slide, but very hard to do in reality. The minute here anybody threatens to close a hospital, people are marching in the street. We need to move from a system that's doctor-dependent to one that's team-based, more emphasis on other kinds of carers. I've just written an article with some nurses for Scientific American arguing that potentially nurses have a lot more to offer than doctors in terms of global health, partly because there are more of them. They're more likely to be in the places where they're really needed. Doctors and nurses to some extent tend to be concentrated in urban areas. Nurses, I argue, are more interested in health. Doctors are, whether they like it or not, predominantly interested in disease. If you look at medical textbooks, they're all about disease. There's very rarely a chapter on health. I think too that nurses are better at following protocols. We have good evidence on that. They're better in teams, and actually I think they can be more effective leaders. I mean, we wrote this piece to be deliberately provocative, but I'd ask you to reflect on the idea that maybe we do well to invest more in nurses and less perhaps in doctors. The Scottish report argues that we need to move from episodic care, which is what we tend to apologise for that motorbike, but it's just gone. I'm not sure how much you could hear it. At the moment, you know, we go to the GP, you go to this specialist, you go to that specialist. We need something that's more continuous, from disjointed care, from the different bits of the system, to something that's more integrated. From reactive care, I wait until you, the patient, come to see me, to preventive care. From seeing the patient as a recipient to being very much an active partner. I think we've made progress with that, but we've got a long, long way to go. That self-care is infrequent to a world where self-care is encouraged and facilitated, perhaps even with resources being shifted in that direction, where carers at the moment in our system are rather undervalued. It's a very tough life being a carer with rather small support, to carers being supported much more as partners. And from this one at the bottom, maybe seems a little counterintuitive, from a rather low-tech to a high-tech future. We might think, well, isn't the current world very high-tech with CAT scanners and such like? But I think the argument here is that we are completely failing to use information technology as effectively as we might. And we have good evidence that you can use IT to keep people in their own homes rather than have to move to hospital. And yet often these systems are not introduced because the incentives within a system are to have people in hospital rather than at home.